Hi, Chair. I confirm we are now live streaming.
Thank you, Tom. Good morning, everybody, and welcome to our Integrated Care Board meeting in public for NHS Herefordshire and Worcestershire. Welcome to colleagues around the room and anyone who's observing us today in our public meeting. We have had a number of apologies for absence today due to annual leave. So I'll just mention the members who have given apologies. Will Taylor, our Chief Medical Officer, Matthew Hopkins, partner member, Jane Ives, partner member, Nigel Fraser, partner member, and Paul Walker, partner member. We are, however, quorate, so I'm delighted to confirm that. So if there are any declarations of interest for items specifically on the agenda, we obviously have our declarations on our usual log, but if there's anything specific for today's agenda, there's an opportunity to declare that now, or if you think of that as we go through the meeting, please do indicate that there is an item in which you have a potential conflict of interest. There is our governance log, which is enclosure number 4, which is for noting. I think if I recall correctly, all the actions on the governance log are closed except for on the action log, except for those that are not due at the moment. Hannah, is there anything you wanted to highlight in relation to that?
No, as you say, Krishni, so we have got some actions that are closed, 2 that are ready for closure, so they're marked as complete, ready for closure. So just a confirmation from board members that you're happy for those to be closed.
Is everyone happy to close off the actions that are noted? Great, thank you very much. Okay, we move on then to the minutes of the previous meeting, which was our meeting of the 17th of May. I think colleagues have already received these minutes previously to this meeting, so I'll just seek your approval for the minutes, but if there are any points of accuracy or matters arising, we have an opportunity to consider those now. Anyone want to raise any points? No, so can I take it that the previous minutes are approved? Excellent, thank you very much. Okay, well, I'm delighted now that we're going to move on to our patient and public voice section. We have not received any questions from members of the public for this meeting. I'll just reinforce to members of the public who might be observing our meeting that opportunity remains available for future meetings, but we will, in the absence of any questions, move on to the patient story, and I'm delighted that our Chief Nursing Officer, Dr. Kath Cobain, is going to lead this item. Kath.
Thank you, Chair, and good morning, Board. Today's deep dive is on elective services, and we know that elective services were impacted in the pandemic, such as delaying routine operations out of absolute immediate necessity to protect patients, public and urgent and emergency care services. In response to this, the NHS launched a delivery plan to tackle the backlog of elective care in February 2022. The patient story today details the personal impact of this waiting for one of our local patients. David is 74 and he lives with his wife Anne, for whom he is a carer for. He started to experience knee pain in May 2020. Self-cared and accessed a private physiotherapist. However, he was still troubled by pain and went to see his GP later that year, who referred him to the orthopaedic team, who saw him at the start of 2019 and recommended a steroid injection. The first injection worked well, and he was subsequently offered a further injection, which was unfortunately not so effective, culminating in David being referred to the orthopaedic team, where he was seen towards the end of 2019, where it was decided that David should be listed for a non-urgent knee replacement operation, as he was mobilising quite well at that time, but he had difficulties with longer distances. Unfortunately, David experienced a significant delay, with his surgery rescheduled a few times due to the impact of the pandemic. He eventually had his surgery in January of this year and is, I want to make you aware, recovering well from that surgery. Personal impacts that David described were struggling to go on walks, which he and his wife had always enjoyed. He found going out on holidays, days out with his children and grandchildren difficult, and shopping at large supermarkets hard. He advised that luckily he owns an automatic car, and as it was his left knee, he was still able to drive. But had it been his right knee, he and his wife would have lost all independence, and they would have had to rely on their children for shopping needs and errands. David explained that the long wait was detrimental to his mobility, which declined significantly over the waiting period. Despite the impact of the long wait, David advised that he felt the care he had received from his GP, orthopaedic team, nurses, anaesthesiologists, physiotherapists, occupational therapists had been exceptional in his view, and that everyone was kind and very apologetic for the delay due to the COVID backlog. So despite the long wait, David felt that his care was good. So once he got the care, it was good, and that he was kept healthy while he was waiting. There are a couple of points of learning that I would like to present, and then I would like to open for questions and discussion. David advised at times he didn't feel the timeline for his planned operation was clearly articulated to him. He would have appreciated regular updates, even if these were not good news. Dates for surgery had to be reprioritised to ensure that those with the greatest clinical need were seen first, rather than patients in wait order, which we understand. We know that providers had to cancel some operations also during winter pressures, and this mainly impacted those who were not waiting for urgent surgery, such as people like David. Surgery scheduling also really needs to take account of the 6-month period post last injection, because he wasn't able to. There was a lag time between that. So we are doing multiple pieces of work across the system to review how we keep our patient informed, including information leaflets, and making sure that we inform them where they're at on the waiting list and progress regarding the waiting list, as well as expanding our library of personalised care self-help resources to ensure that people keep well while they're waiting. This is very much a work in progress and continues as we speak. The second learning point that I'd like to highlight, the wait for surgery impacted Mr. Smith's mobility, and there was evidence of further deterioration over time. Did this risk poor outcomes or cause potentially hidden harm? If there had been any major or significant harm had been attributed to the delay, it would have been reported as a serious incident, considering through the patient safety specialists if there's anything else we could do. So we are working actively through the new patient safety, the patient safety agenda, to consider if there's anything else that we can do to capture lower levels of harm and put improvement plans in place to address these. I'd like to pause there, open up for questions and discussion. Thank you very much.
Thank you, Kath. A really important story in the context of the sort of items on our agenda, really, that we have later on. Can I take the opportunity to ask colleagues if there are any questions or comments they wish to make regarding the story? Simon, first of all.
Yeah, morning all. Simon Trickett, Chief Exec of the ICB. Just a reflection, really, Kath. I'm well cited on the work we do reviewing harm at system level. I'm just interested in how involved are the clinical teams managing these services in consideration of that harm? Because we talk a lot, don't we, about we have waiting lists, but we also try and prioritise according to clinical need as well. So it's just playing in that there's a very active kind of day by day, week by week harm review process, which does involve people being shifted around the waiting list. I think that's the case, isn't it? But I just thought it worth exploring that as well.
Yeah, absolutely. There is with a provider's active sort of harm review process. I suppose in aspects like this where the harm might be sort of lower level and go under the radar, that I think that's what we're like kind of probing. And I think the new patient safety, the PSERF that we will discuss at a later time, is really about looking for themes and then looking for how you can actually sort of do some of that work rather than just concentrating on the individual harm, thinking more in a wider population basis. So absolutely, there are processes in place.
Thank you. Couple more questions. First of all, from Mark Yates.
Thank you, Krishni. Thank you, Kath. I'd like to ask around the communications and the lack of knowledge our patients sometimes have with regard to what happens next and when. They often know the next, it's the when, and this isn't just in elective care that you raised this morning. This is across a whole plethora of things. And I do wonder whether we have any form of standards, or should we have any form of standards across the system with regard to how long we leave a patient not knowing when the next thing is to happen to them. It's probably a very clumsy way of describing it, but whenever I talk to patients, which obviously is relatively regularly, that's one of their main issues, is the not knowing. And I think your patient this morning described that. It's they accept waiting lists, they accept prioritisation based upon clinical need. What they struggle to accept is the not knowing. And I wondered whether there's anything we can set as standards or expectations across the system to fill that gap.
I absolutely agree with you, Mark. I think that's it's the anticipatory, when is it happening? I think we would all appreciate psychologically that for anything that we go through in life, the not knowing is really difficult, and it's that good communication. Now, within the patient story, probing that bit, he felt he had good communication, but again, I absolutely agree with you, and I don't know if Jade would want to come in, but there is specific work going on within elective care to make sure that we're improving that, and wider than elective care, because obviously from that operational delivery. So I don't know if Jade wanted to come in on that at all.
Jade, would you like to come in?
Yes, thank you, and good morning all. With regard to patient communication, I think an important bit to pull out there is our personalised care programme, whereby we've created a library of materials to support and encourage patients to seek communication and make more of shared decision making between their clinician and the patient. But we do accept that health literacy is a challenge for some members of our community. So alongside that, there's a programme of training for our staff across all our organisations in our system about personalised care, so that we can encourage patients and make that broader, really, patients and their carers to be able to access the information they need. So we've got some things in train, and I'll return to that as a theme within the deep dive.
Thank you very much, Jade. I mean, Mark, I think you make a really important point, and Kath referred to it in talking about the story. I seem to recall that the Parliamentary Health Ombudsman, who look at the escalated complaints, has always highlighted communication between us and patients as a sort of common theme. And I think it's about managing expectations, isn't it, and making sure that people aren't, as colleagues have said, not been left without information. So the more we certainly can do on that front, the better I think we can support people. Of course, we would ideally want to reduce these the rates of waiting, which is the other part of what we're going to come to, so that actually patients aren't waiting unnecessarily long periods of time for care. Nikki, please.
You could point out, Kath, the amount of extra resources needed because so extra therapies.
Sorry to interrupt, Nikki. You're very faint, unfortunately. You'll probably just need to speak up so that we can hear you.
Can you hear me now?
Just about hear you, I think. Just.
Don't know. There might be a problem with my mic.
That's better, I think.
Kath pointed out all of the extra resource that was needed to look after the patient because of the wait. So extra therapies, extra consultations with his GP. I just wondered whether any impact of this is being looked at as part of the delay on the impact in the rest of the system because that invariably has a knock-on effect in making other people wait for access to those services. So it's not just the wait for the surgery itself. So have we looked at that at all? And then how will we address it collectively across providers, the impact of the wait in one area on the rest of the system?
Thank you, Nikki. I'm sure we all heard that. I think that was clear enough. Kath, do you want to come back in on that?
That's an excellent point, Nikki, and I think that's the whole idea, isn't it, of integrated care systems and being able to quantify what goes on here and the unintended consequences or impacts in another area, and that is the whole way. And I think through the way that we're working in thinking through our planning and going forward is about, you know, how do we need to structure services around the patient to make sure that that they're also the most equitable for everybody, and that we're not spending money in one section where we could actually be spending money differently, and spending money in the prevention sphere as well. Just thinking about things that could be done in prevention, sort of in these cases and things like that. They're thinking about weight management, keeping physically active and things like that there. So I think it's thinking about those pathways and making sure that we are doing that and working together. And I think through looking at things in a system perspective, I think we have much more opportunity to do that. But to say it's been fully bottomed out from this case, I wouldn't like to say, but that's absolutely the spirit I would see as the way we're working forward in an integrated care system.
Thank you, Kath, and thank you, Nikki, for the question. Sarah?
Thanks, Kath, for presenting that. I think the point that I wanted to make was one that you illustrated, I think, at the start of the presentation by saying this gentleman was a carer for his wife. And whilst I think Simon picks up as well in his paper, clinical prioritisation, I know it's incredibly difficult to take into account people's wider context. And Jade talked a little about personalised care and personalisation. But for this gentleman being a carer, we don't know other sort of socio-economic factors or those sort of complexities. And I know that puts things in a difficult and different political perspective as to how we move beyond clinical prioritisation to considering those wider factors. But I just wonder, in this case, whether the fact he was a carer would have had any consideration in his prioritisation, and indeed should it, and should we be considering these wider factors as well?
Excellent point, Sarah. And I think one of the pieces of work that we did, you know, prior to being a system during the pandemic was to make sure that we were really looking after carers in the pandemic. And some of this was like flagging that on GP systems and working around support, and whether I think this gentleman was able to utilise and go and purchase private physiotherapy and had an automatic car, things like that mitigated his circumstances. So I think you know, but you're absolutely right to bring that up, because that may not be the case for other people. And I suppose you open a debate therefore as to whether that should come into a clinical prioritisation framework, which obviously is prioritised on clinical need for the operation. But I think an excellent point, and definitely something to think and debate forward.
Thank you, Sarah. Yeah, there's a lot of wider elements to this, isn't there? Lots of, as Nikki and Sarah, I think, have raised, lots of other considerations beyond what we perhaps traditionally tend to think about when we're prioritising. And actually, therefore, it does, you know, in terms of our maturity and development as an integrated care system, a lot for us to think about how we could do it differently and how much more efficient, and in addition to the better experience and the better outcome for the patient, how much more efficient and making best use of our collective resources we can do by improving the sort of processes and pathways that we use, really. So, Kath, any final comment before we close on this?
No, just thank you very much, and thank you for the discussion. I think it's a very good discussion and some definitely interesting points to take forward, as you say, Chair, into our debates around our development as an integrated care system.
Thank you, Kath, and thank you to David for sharing his story, because it's really important for us to reflect on the lessons we can take from this, as you've highlighted, and focus on those as ways in which we can improve. So thank you, everybody, for your contributions to that discussion. We move on then to our strategic update section, and the first item on that section is Simon's report as Chief Executive. Over to you, Simon.
Thank you, Krishni, and I'm just taking it that people have read the report, but as usual, I'll draw out a few points. So on page 1, some pretty significant leadership changes in our system. We talked about this, I think, at our last meeting, but the appointment of Glenn Burley as the Chief Executive of Worcestershire Acute Trust, which takes effect on the 1st of August. The Trust seeking permission to be full members of the Foundation Trust Group, and NHS England considering our recommendation to appoint Russell Hardy as the Chair, are all significant strategic moves, particularly in the provider collaboration space, and we'll touch on a number of issues today that will be related to this, particularly in relation to fragile services and sharing best practice around some of the operational challenges in particular that we're facing. In addition, there's been a local election in Herefordshire, and you'll notice we have a new lead member in the Cabinet, Councillor Carol Gandhi, lead member for Health and Wellbeing, and a new leader of the council as well, Councillor Jonathan Lester, who he was the leader of Herefordshire Council just over 4 years ago. So we have worked with Jonathan previously, but it's important, I think, the board are kept aware of significant leadership changes locally, because we're a system and these people are now an important part of our system architecture. Would be remiss of me not to mention the long-term workforce plan, the much awaited long trails workforce plan that did appear a couple of weeks ago. You'll see a headline summary of the 3 areas of the workforce plan that focus on training, retaining and reforming how we work with our workforce. We will be coming back to this, Krishni, later on the board agenda, I'm sure, later in our programme during the year, as we try and digest how we can take forward some of the opportunities. But clearly the increase in medical school training places is one of our first priorities, really, working with the 3 counties medical school to try and support their position to get training places for clinicians, for doctors locally, which is important. Again, I should mention industrial action. So there's an ongoing programme of industrial action, and we just finished yesterday another junior doctor strike. We're going into, over the next couple of days, the first consultant strike it's new territory, really, and it's significant. And I don't think we can underplay the impact of the ongoing industrial action, mainly on our people, mainly on the people who do have to do extra work to cover the absence of their colleagues. And of course on patients, and we'll talk a lot today about elective care and waiting lists, and particularly in relation to the consultant strike, there will be people over those couple of days who we would have wanted to have had their operation, their procedure, their outpatient appointments, but those will be cancelled because of the strike action. And we obviously try and keep that as a minimum, but I think the strategic point is the ongoing nature of these actions are causing a significant issue for the well-being of staff, really, I think is the best way of describing it. Page 5 describes some work and particularly some demand challenges in children's services that, again, I know are a feature on our risk register, but there is significant increase in demand across a range of children's services. Some of that is post-pandemic, some of that is waiting list and backlog, some of it is new need that we need to adapt our services to try and make sure capacity more closely meets need and demand. And there's a lot of work going on in that space, particularly with both local authorities, who obviously, as we've talked about here before, are both on differing but similar improvement journeys in children's services. And I think the report also picks up some good work we're doing around learning disabilities and autism. Again, an area where there's been some quite significant increases in demand, And we have got some areas for improvement here, but on the whole, our learning disabilities and autism services perform really well and do a really good job of meeting need in quite difficult circumstances. Again, I should mention on page 7, Krishni, the Care Quality Commission have been working with Herefordshire and Worcestershire Health and Care Trust and a well-led inspection over the last couple of months. The report highlights some of the early findings. We still await the final report and any judgments, but I think the point I'd make is we are working with the trust to try and be proactive, to listen to those concerns that have been identified and get on now with making some of those improvements. And the system and the ICB in particular, we're 100% behind Sarah and Mark's teams in trying to help with that improvement journey. It's really important that we support that. And I want to finish on some good news. So you'll see on page 8, we've been responsible for commissioning dental services since April, and we have just worked with the NHS England team that have transferred across to us, and we've managed to place 2 pretty big new contracts for dental provision in Herefordshire, both worth about £5 million, so a significant increase in dental access in Herefordshire. You know, it'd be great to claim all of the credit for that, and that's all because of our influence, but I certainly do think we've managed to make sure that proposal and that contract got over the line, and I know that will start to make a big difference. It's the first step in quite a long journey of improving dental access locally, but it's a significant step, and I think it's something we should be aware of. So very happy, Krishni, to take any questions on those items or anything else in the report.
Thank you, Simon. Really helpful. Some additional insights or some highlights from the report. So questions for Simon or comments on anything that you've read within the report. So firstly, Sarah Dugan, please. Sarah.
Thanks, Krishni. I just wanted to comment on the dental access, which is fantastic news, because I know the team have been working on this for a long time, but I just wondered what's made a difference, Simon, that we've suddenly managed to get 2 big contracts, because I know this work has been ongoing for some years. So just be really interesting to know what are those key success factors, because it's whether we can then replicate them for other areas. And I suppose my other point is there's going to be so many people keen to access this service. I don't know whether we have any influence in the contract over prioritisation.
Yeah, sure, good question, Sarah. I mean, what's made a difference, and I think it's one of the areas we've already been able to influence, is a more open and creative approach to the tendering. So we work with NHS England to say you keep offering this national contract at this national price and nobody's interested. You know, if you keep doing the same thing over and over again, it's no surprise when it doesn't achieve different results, and that's a lesson we learn across the board, isn't it? So the things that we have worked with the team to introduce in Herefordshire are 2 things really. One, an additional investment in infrastructure, because setting up new dental practices obviously comes with work. So there is a sum of money, I think it's £100,000, that's available in these contracts towards new infrastructure costs to deliver the new service from. And secondly, there is a golden hello, a bonus payment for people taking up this contract. So again, a recognition that starting a new service requires a whole load of additional work to get it set up. So those 2 things in this case seem to have made a difference. I think my only caution is, you know, we need to keep innovating and keep thinking outside of the box to try and get better answers for these services. Provision's really poor, really poor in Herefordshire, and it's not fantastic in Worcestershire, and we are going to have to continue to be creative. I think the second point's a really good one. And Sarah Raystrick, I'm sure, will back me up. One of the key service access issues that we could tackle that would reduce health inequalities is access to dentistry, because dentists pick up a whole load of associated health problems and are a great early warning for a number of other conditions. So we're going to work with the new providers, and it's something we want to do across the whole system footprint, to put in place systems and processes whereby people with greater need, people who come from postcodes and areas with traditionally bigger health inequalities, where we can find ways of maximising their access. So none of that's formalised yet. That's not part of this contract, but that's very much the intention, that we get to a place where we can target new capacity at those populations and communities where it can make the biggest difference to health outcomes.
Thank you, Sarah, for the question, and Simon for the response. I mean, I think I think you've highlighted a really important issue around inequalities, and actually we having been to the recent launch of the joint health and wellbeing strategy for Herefordshire, I think, you know, it's notable that oral health levels within particularly children and young people in Herefordshire is very poor, and therefore you know, access to dentistry is obviously a significant issue. So it's really positive, this development, and obviously more work to do as well, but a really positive one nevertheless. David.
Thanks, Krishni. Simon, I'm going to apologise in advance for a comment and a two-pronged question which jump around from across your report. The first kind of comment is, like you, I really welcome the NHS long-term workforce plan. I think that's really great to have that finally out there. My comment, though, would be that you mentioned train as being very important. I think as an ICB and as a system, we need to be looking also really strongly at retain and making sure that we have the right culture in place, that we have the right conditions for our workforce to be happy and to work well and to remain with us. So I just, I'm sure you agree with that. I can't imagine you don't, but I want to just kind of balance that focus. And the question is to do with the point prevalence audit that we did last year. So we did a great point prevalence audit. I think there's a huge amount of work went into that, and it went really, really well. I just wanted to ask what actions have been taken as a result of that, and what confidence we have that when we do a new point prevalence audit, that the outcomes will be different in this September compared to last September.
Yeah, thanks, David. I mean, I agree with you on retain. I mean, it's great actually that the workforce plan recognises there's much more to improving our workforce performance generally in its widest sense than just training new people. We've got to do things differently, and yeah, critically, we've got to treat people better and provide better environments, terms and conditions, and more flexible employment options to try and keep more trained people in the workforce for longer. So totally agree with you. The point prevalence work, I mean, that's a complicated piece of work, and what we see it as, we see it as part of, it's an ongoing process of understanding and reviewing where people are receiving care, what the opportunities for improvements are. Critically, it's leading into the work that we're about to finish in the next month on longer term demand and capacity planning. So if you remember rightly, we did the point prevalence audit last September. The results became available towards the back end of the calendar year. That led us as a board through a whole series of strategic conversations, didn't it, around opportunities to move resource, to move capacity. All of that then is reflected in the joint forward plan that we're going to sign off today, that we discussed at our development session, and all of the other work. So it's not as black and white saying, yes, we did A, B, C and X, Y, Z with the impacts. I think we have made improvements. I think it's a different picture in our two counties, if I'm honest. I think in Worcestershire, we continue to make improvements on people being in hospital unnecessarily, and our criteria to reside figure, that figure that measures how many people are in the hospital who don't need to be, it has always been quite low, and it's continued during the last 12 months to be pretty much the lowest in the country almost every time it's reported. That's not the case in Herefordshire. I think, if I'm honest, in Herefordshire we haven't made the progress with reducing criteria to reside that we want to. We're trying different ways of tackling that. Specifically, that's a big part of the place-based delegations in Herefordshire, and the MOU we're about to sign with Jane and the team includes a big emphasis on the work that they're going to lead, redesigning the Better Care Fund in Herefordshire and some of those discharge pathways. So I think it's a long journey. I think it's harder to see very specific changes, but every week things happen as a result of that point prevalence audit and that information. Every week we're taking decisions to take that forward. So I hope that's helpful. Sorry if that sounds vague, but it's not one of those questions I can just say, yes, that's the answer.
Understood. That's really helpful. Thanks, Simon.
Thank you, David. I think it's part of our our methodology for demonstrating quite long-term or medium-term change and aspirations for providing care in better settings for our community. But hopefully we will see some changes in the data that when we repeat the exercise. And I think it is I think it might prove quite an interesting case study in sort of different ways in which systems are measuring how we progress in the changing the way we work. Sarah, finally.
Thanks. Just a comment and then a quick question. So the comment really is to say thank you for including reference to the community children's services. Good to see the additional investment and the plans that are there, and really to acknowledge that both for the children themselves and for parents of children with complex needs and special educational needs, this is a well needed and often under thought of service, and so thank you for referencing it there. And I think as a board we'll look forward to seeing the sort of the monitoring and the progress as we go forwards. And then I just wanted to pick up, and I don't have a well formulated question, so I apologise, but it does throw up a lot of questions on the tier 4 beds for children that you reference in the report, that many children are diagnosed at admission at a crisis point. And so I think it just throws there for me questions as to, is this the most appropriate time to be diagnosing children? What happens to those children once they're diagnosed? And really not to delve into that now, but I think to seek assurance that we've acknowledged it's written there in your report. Are we going to do robust clinical work and work with our partners to see how we can make lives better for these children so that we don't reach crisis point and they don't end up in tier 4 beds? A rather large ask, I'm sorry, there.
I mean, it's a large ask, but it's a really good, insightful question, Sarah, because because you've been involved in this for a long time. The tier 4 bed, so this, for people that aren't brief, this is children and adolescent mental health services. It's the most poorly children with the highest amount of need. Traditionally, what's happened is the local pathways have dealt with needs at tier 1 through to tier 3. Tier 4 was a specialised commissioning service that NHS England led on all of our behalfs. Tier 4 capacity across the country has always been really constrained. So what happens is local systems, and Sarah might want to come in, our strategy for 10 years plus has been, how do we get more capacity, particularly at tier 2 and tier 3? We've even had a tier 3 plus, anything to try and keep children away from the queue for tier 4 beds, which are also often distributed all across the country. So it means they're moved away from their families and their communities, and visiting becomes really hard. So absolutely, it's a great example of where all of the focus needs to be on upstream investment and intervention and providing local support, doing everything that we can to avoid that exacerbation of need, which means tier 4. We're a long way from that being perfect, but absolutely 150% is the strategy. I think the wider point I'd make as well on children's services, and we're having some interesting conversations now with colleagues about planning for next year. So the financial planning, Mark's working with the Chief Finance Officer as the Director of Strategy involved. One of the things we'd like to do is to be more explicit about creating an investment pot for children's services. I think strategically, children's health needs are increasing at quite a pace, and as I said, the pandemic is part of that, but actually that there are wider issues at play here. We've got to get our capacity more closely aligned with those increasing needs. So really, if there's one area I think where we're going to have to carve out more resources for the coming years, it's going to be in children's services. So what's in the report and the conversation we've just had around CAMS, they're actually really good insight into a wider issue, which is rapidly increasing demand and the need for the health services and social services and partners. We're all going to have to put a lot more resource and focus in this area. So it's a good opportunity, Sarah, to share that point, really.
Thank you, Simon, and certainly I'm aware very much that this pressure exists in other parts of the country, and I know there's some work going on in the East Midlands, working where all the, certainly for CAMS, the which Simon mentioned, a number of East Midlands trusts are working together and have actually created a slightly different model, loosely described as tier 3.5, as an intensive support offer. So that might be something. Sarah, I can see Sarah's put her hand up, so she may wish to comment on that. Sarah?
Yeah, I was just going to make a similar point. So just to remind everyone that the West Midlands mental health providers work together as a collaborative, and this is one of the key areas of priority. And I think, as Simon's alluded to, one of the key benefits of that way of working is about the ability to look at the whole pathway, shift some of the emphasis of where the engagement and the input is to support children before it escalates to the higher tiers. So we are seeing quite a bit of success from that work already in terms of a real impact on the number of children in the high level places. So really positive signs so far, but very similar to what you're describing, Krishni, is being progressed in the West Midlands to help this agenda.
Thank you, Sarah. And I think what that illustrates is the importance of the partnership arrangements beyond our local system, where appropriate, that sometimes some of these areas really require us to work at different scales, as we've recognised. So in particularly specialist services, working at scale sort of across region, it can be particularly helpful, and other times this will be very much a local initiative. So our ability and opportunity to explore those, I think, will remain really, really important as we go forward. Thank you everyone for questions and comments. Thank you, Simon, for the comprehensive report as ever. I particularly just wanted to echo Simon's thanks to staff who, you know, these are difficult periods of time with industrial action and other things going on. So just really want to recognise all the efforts of staff who continue to step up to many of the difficult challenges we're working together on, and important to recognise that our job is to support them in those endeavours. I also want to just take the opportunity to thank Councillor Crockett, who was the chair of our Integrated Partnership Assembly, and who now Councillor Gandhi has now taken on that role, but we've worked really well with Councillor Crockett too, so I just wanted to acknowledge that, and look forward to continuing our really good relationship with Councillor Gandhi. So thank you very much. We move on now to item 9 on the agenda, which is our joint forward plan and ICB objectives. So over to you, Hannah.
Okay, thank you. So I will present this item on behalf of David Mahaffey. So yeah, you will be aware that the Integrated Care Strategy was approved by the Integrated Care Partnership in April. And the next step on that journey is the creation of the joint forward plan, and the board has received periodic updates about the development of the plan. So there's a mandatory NHS guidance that requires that a 5-year joint forward plan is created by NHS partners, and this is then the NHS contribution to the integrated care strategy, as well as the joint local health and wellbeing strategies. So the plan has been co-produced and owned by all NHS partners, and I know that the level of engagement has been really great and very welcome. The Health and Wellbeing boards endorsed the plan in their meetings in June, and NHS partners have endorsed the plan at the ICB board development session also in June. So the plan has now been published because the deadline was the end of June. We're bringing it here today for formal approval or endorsement in public. So it's slightly retrospective, if you like, but the timings kind of didn't allow us to do it differently. So the next sort of step on that journey is the creation of the ICB objectives. So we have had previously ICB objectives which have been agreed last year, and they were agreed for 18 months. So this is not really necessarily something different. It does flow out of the joint forward plan. There's a strong alignment to the previous objectives, but they have been reframed and reviewed to really fit in with the joint forward plan. So they are structured around 6 key areas, focusing on quality, finance, health inequalities, operational delivery, system development, and ICB corporate development. These are then further broken down into specific actions and areas of focus. They have defined success measures and timelines. They're owned by ICB committees and ICS program boards. And they have got an allocated ICB executive or partner member to really stress that accountability and ownership. And that will obviously flow then into the ICB board assurance framework, and we will be monitoring delivery against those objectives and any risks that will potentially threaten delivery of those priorities and objectives through the board assurance framework and in the various ICB committees. So the link to the plan as well as the appendix with the objectives have been included within this paper. So I'm happy for you to take happy to take any questions. And today I'm just asking for a formal endorsement of the joint forward plan and approval of the ICB objectives, please.
Thank you, Hannah. So obviously these are things that we've looked at in our previous meetings, particularly the joint forward plan, which I think colleagues were happy to support, but important just to note that, I think, in public. So any comments on either the joint forward plan or the corporate objectives, which are there for you to confirm your approval for? Okay, no, nothing particular. Sarah, Rachel?
Sorry, just a quick point, and I have picked this up with David and had a really comprehensive answer from him. I was just interested in the corporate objectives for quality. We talked about access and experience, but not outcomes, and we normally link the 3 together. I think it was implied that we would obviously use outcomes as a quality measure, but we were just perhaps going to look maybe at a bit of wordsmithing on that, or agree that it is implied that we will look at outcomes as well within quality.
Thank you, Sarah. So you've obviously had that conversation with David already. So shall we, are you happy that we approve it subject to kind of final confirmation on whether we make a slight change to reflect that, or note, as you say,
absolutely. Thank you. I just wanted to acknowledge that David had done a thorough response to me, but we had that conversation beforehand. Thanks.
Great, thank you, Sarah. Excellent. So in the absence of any other comments or questions, we as a board then formally endorse the Herefordshire and Worcestershire joint forward plan and approve the corporate objectives for 23-24, but with the proviso that we'll just take the opportunity to consider the reference to outcomes that Sarah has highlighted. Okay, we move on then to item 10, which is committee escalation and assurance report. So Hannah, did you want to introduce this, and then I'll invite the chairs to come in?
Yes, I can do, Krishna. Yes, thank you. So this is a slightly new format. So you will have noticed we've changed the format on this report a few times. We're trying to get it right. So any comments on that really, or feedback, really welcome. So what we've tried to do is to kind of really pull out the key points from each of the committees through an alert, advise and assure methodology for the board to really be kind of to, you know, rather than drown in the detail, to bring to your attention really the elements of committee discussions you need to be aware of. So we have done this for all committees that have met since the last meeting and have attached the highlight report as well as any minutes that require formal endorsement.
Thank you, Hannah. And this is an approach that's being used in different parts of the NHS. So helpful to note that it's a sort of benchmarked example, just demonstrating learning from other systems as well. So I just invite chairs of the various meetings, if they wish to make any comments. Obviously we can take the report as read, because I think it's very clear in what it's bringing in terms of attention to the board. But I'll just invite chairs, if they wish to comment, to do so. So first of all, relating to quality resources and delivery, I know David was deputising for Vicky on that committee. David, anything you want to bring to the board's attention particularly?
Yeah, thanks, Christian. No, not at all. It's all as reported in the report.
Great, thank you. Any other? I'll perhaps not go through and ask every chair, but is any chair very keen to come in to highlight anything particularly? Vicky.
So I just wanted to, the template is really helpful, and I think it's a really helpful way for the board to be cited on the committee's work. What I would say is some of the issues that are in the alert section, it would be helpful going forward if we actually put how long that's been on the alert for that committee, so we can actually see perhaps the issues that are becoming troublesome and long term. So some of those issues have been long standing, so that from a public facing point of view we can understand how long that's been a concern to us as a board.
Thank you, Vicky. So Hannah will reflect on that as a sort of further development. I do think, and there was one question I wanted to probably just raise, and I think it was relating to the AGM timing. I seem to recall a reference to the AGM in the report. I don't know if anyone can help me as to where I might have seen that. It would have been probably in relation to the audit committee.
Yeah, Krishni, I think, Graham, I think it was in the audit report, and the last I heard, Mark may comment on it, that we were looking at an AGM in potentially November.
Okay. That's helpful to note. I think it was just referenced somewhere as something to be confirmed, and perhaps for the board to note. Mark.
Thank you, Chair. So from a timeline perspective, yes, that was the timeline we were working to. We are, however, just waiting for a formal engagement offer from our external audit partner. So this is all reliant on our external audit of our accounts for 22-23, which we know we've had some challenges in trying to secure a new audit partner. So subject to the timeline, they confirm we'll still aim for November, but it's just a flag, Chair, that we may have to come back subject to how the audit goes and the audit period, just to discuss what that AGM timeline might look like.
Thank you, Mark. Good to have an update on that. Okay, if there are no other questions or comments from committee chairs, then I think it's for the board to note the key decisions and discussions that took place based on and on the content of the reports using this new methodology. I think, note the feedback from Vicky regarding making it clear that it's been a concern for a committee for a particular period of time. We're obviously asked to note the suite of committee minutes as well that are available for transparency to the board, and asked to take assurance that the committees are discharging their responsibilities as delegated effectively. So thank you very much to the committees for the work that they're doing, and to colleagues who chair those committees. So with that brings us to our next, our deep dive on elective care and diagnostics. Conscious that we might want to spend a little bit of time on this, I'm wondering whether we take a break now, a short break now for 10 minutes to get some refreshments, and start the meeting at 10:30, restart the meeting at 10:35, to continue with the deep dive on elective care and diagnostics. Is that okay with everybody? I suggest, obviously, as colleagues are aware, this is live streaming, so please turn your microphone and camera off if you're leaving the meeting temporarily. Thank you. Just make sure everybody is back and then we'll start momentarily. Okay, welcome back everyone. So our next item on our agenda is our deep dive that we do at every public meeting, and today the focus is on elective care and diagnostics. I think Jade has stepped into Mary's shoes today. So welcome, Jade. Good to see you here. Obviously, it's a very comprehensive report, so we'll take the report as read. But if you wanted to highlight any particular points for our attention, and then we can go to questions and discussion, so we can explore the topic in more detail. Over to you then, Jade.
Thank you. So the oversight of this area sits with the Elective Cancer and Diagnostic Programme Board, and its areas of interest are summarised on page 2 of the report. These activities are addressing elective recovery post the COVID pandemic and modernised provision to meet our current and future demand. The key priority is around reducing waiting times. So in terms of that, page 3 of the report describes the trajectory for the 78-week waiters, and I'd like to draw to your attention the progress achieved to date. And based on this performance, it is with confidence that I can say that the system's on track to achieve no patient waiting longer than 85 weeks by the end of March 2024. As of June, that's currently 27,000 patients in our system that could be at risk of waiting in excess of 65 weeks. I could say that with confidence because the actions that we've identified are firmly in place, and that's been achieved through collaborative working across our system, mutual aid between our 2 acute trusts, but also engaging the independent sector in terms of extra capacity and provision for some of the key specialties where the waits are longer. But it's also been about transformation and productivity. Page 5 of the report highlights a number of areas of excellence. You'll be aware that the system has secured funding to continue to develop community diagnostic centres, but I also want to bring to your attention the work on specialist advice, where as a system we're one of the leaders in England in terms of our performance there. And that has been down to the engagement of our clinicians, both in primary care and secondary care, to come together to work on things like education and top tips and guidance between each other to make sure that we take full advantage of specialist advice from secondary care to primary care clinicians. Pages 6 and 7 of the report outlines the areas of transformation. A significant area is our work on the outpatients programme. This includes a number of areas, including patient-initiated follow-up, whereby patients take an active role in determining if they need a follow-up and when, but also virtual consultations, something that we grew and developed during the COVID pandemic, and therefore continuing and embedding that into elective care practice today. In terms of guidance implementation, I just want to take the opportunity to assure the board around the implementation of the patient choice guidance that was issued earlier this year. This links back to the patient story we heard earlier. And the patient choice guidance is a requirement that we must have and commission up to 5 providers so that our patients can make an informed decision about where to have their assessment and treatment. At the moment, we're working on a plan around that and making sure that we have the correct accreditation process in order that more independent sector providers can join our framework and therefore be available for our patients. In the short term, indeed, that will help to continue to drive down those waits I mentioned earlier. In terms of waiting times for diagnostics, I'd like to confirm that the waits have improved, but please note we're undertaking more work to ensure that all diagnostic modalities achieve that performance, and the report outlines a number of areas that we're working on. The report also comments on productivity and sustainability. These are the biggest issues for us, both in terms of the transformation activities outlined in the report and our engagement in the NHS Getting It Right First Time programme. On the issue of sustainability, there are some specialties that are more vulnerable than others, and the report on page 11 outlines those specialties that we're concerned about, mainly challenged by the workforce issues currently. One of the challenged specialties is dermatology, and I would just like to add to the report that this has recently emerged, and we have a full partnership meeting next week, and we've invited the trusts all along our borders. Again, another example of collaborative working and the way of addressing our elective waits. Lastly, I appreciate there's a lot of detail in this report, and as you've said, Chair, we'll get into the detail, and I'm happy to take questions.
Thank you very much, Jade. Okay, any comments or questions then for Jade or colleagues around any of the issues raised within the report? Mary, first of all.
Thank you. So just a comment, really, not a question. Whilst we've spent the last couple of years, obviously post-pandemic, focusing on recovery and and dealing with the inevitable fragile services that come along our way, we now want the Elective Cancer and Diagnostic Board to look forward in probably to the next 5 years. How we're going to sustain our services, what models of care are we going to put in across our ICS to make them sustainable, what pathways, what workforce are we going to use. That might mean some change of models of care that we'll as a board have to consider going forward, but rather than trying to keep services as they're going now, which we know is not the way to do this, we're going to look forward as well. So in future boards, we'll be bringing back in particular areas new models of care to be signed off through our governance that we can implement.
Thank you, Mary. That's really helpful. Yes, as you say, we've been in recovery mode for some time, haven't we? Right, a number of questions have come in now, or comments. So first of all, David, and then Graham. David first.
Thanks, Krishni. It's great to see the improvements in productivity and efficiency. As we were going through the financial plan, it felt like our system was quite challenged in improving productivity, and yet here it looks like the productivity is improving. Which is the correct picture? Is it the correct picture that actually we are making big advances in productivity, or is the correct picture that actually that we're struggling to make advances?
Thank you for the question, David. So with regard to productivity, we are making advances. You can see on page 11 the GIRFT, in terms of theatre, touch time and utilisation. However, for all the productivity that we are achieving, our recovery in our backlogs is meaning that we currently need more capacity than the efficiency and productivity demonstrates. Once those backlogs have reduced, we should therefore be able to run a more efficient system to manage the demand that we would usually expect. So hopefully that's helpful.
Okay, thank you.
So it's sort of both and, isn't it? We are improving our efficiency, but there's more work to. I think the real challenge or the real opportunity is once we've addressed the backlogs, I think is what you're saying, Jade. Mary, did you want to comment additionally on that?
Yeah. It goes back to what I said a few minutes ago. Once we've delivered those backlogs and got back to an RTT position that's stable, we then need to look at the best model of care, the most efficient model of care for our ICS going forward. Some of our services are so small, they're always going to be fragile, and inevitably they cost a lot of resource. We've got to think how we do them differently to have the same, if not better, outcomes, but in a more cost-effective way.
Okay, thank you.
Thank you, Mary. And Graham?
Thank you, Krishni. Yeah, it's really, I think the point may have been covered, Jade and Mary. It's just building on that theme on sustainability, because I was just interested in what the reliance on the independent sector was in the recovery, and do you see that likely to continue?
Jade, do you want to come back on that?
Thank you, Graham. Yes, at the moment our system has quite a reliance on the independent sector. Some of that is intended, i.e. they're a key part of a delivery of a pathway. So for example, our community dermatology pathway is supplied by an independent provider. Some of that has been intended in order to address the backlogs, but going forward, we would like to have more of an economy where we have secure and stable NHS provision in partnership with the independent sector, rather than trying to use the independent sector to address our backlogs. So it goes back to what Mary was saying. If we can have a sustainable pathways, including that role for the NHS and the independent sector, then we'll be in a better position. The patient choice guidance I mentioned earlier is a potential challenge to that, whereby providers that are signed and able to deliver against NHS contracts in other places have the right to ask the ICB to also consider them to provide in this area if they meet the criteria under the NHS contract. So for some of our specialties, we could see an oversupply of provision, and yet in some other areas we may not see any encouragement from the independent sector. It's a real balancing act, and therefore our market management and our engagement with the independent sector is crucial.
Thank you very much, Jade. Sarah Raystrick, please.
Thank you. It was a comment really again about, we've mentioned a few times today, the patient portal, and that's in the report. And I think that has the potential to be something that's really, really transforming for a lot of our patients, doesn't it? If we get that right. It was a comment really to be really to look at how we're going to help to educate sounds pejorative, but how we're going to help to work with our public to help them both on patient-initiated follow-up, use of the portal, and the fact that remote consultations with a target of 25% actually can still deliver excellent clinical care. So assurance really that we'll be helping our populations to understand this. And whilst obviously this will help us to meet some of our targets, there is good evidence that for many specialties, including primary care, which interestingly, but not an aside, don't have that target and in fact are encouraged to work in a more face-to-face way. But actually there is good evidence that remote consultations can produce really good outcomes.
Thank you, Sarah. And Jade, do you want to come in on that? I mean, I think the only additional, I think the patient portal sounds like a really excellent development. Of course, we do need to also think about patients who aren't digitally abled in quite the same way. So I just wondered, Jade, if in your response you could just comment on that aspect as well.
Yes, certainly. So alongside all of the outpatients programs, the promotion to the public about what are they exactly and how to access and what does it mean for me is a key part. So we've got, as I said, a patient library, but we've also got literature, and we're also using clinicians to do videos on YouTube and things like that to really encourage what it's about. Our partner HealthWatch is key to us in helping deliver that key messages to the public, and also we're creating a series of posters that we hope will go up in GP surgeries as well as hospital settings, so that people get used to seeing those messages and what does that mean, and knowing where to ask as well is crucial. In terms of the ability to access the portal and consideration to people that may have anxiety or feel uncomfortable about accessing the portal, we've got a number of things underway. So firstly, can I confirm that alongside usual processes will continue to exist, i.e. you could still pick up a telephone and speak to someone. We're also going to be targeting carers and advocacy organisations to be really explicit that we hope people can support others to access the portal. So as a patient, I can determine who sees my information, and I can give access, full access or partial access, to my loved one or my relative to help me with my portal. So again, there's some key messages we're going forward. And then lastly, our whole digital programme has an element of health literacy. There's no point in having a portal if we are extending our health inequalities. So the digital programme are working alongside the local authorities in particular around their community endeavours.
Thank you, Jade. Thank you very much. Graham, is that a legacy hand? I think that's the technical term these days, isn't it? Legacy hand has come into our conversation. Thank you, Graham. Vicky, please.
Thank you. I just wanted to comment, Jade, on the diagnostic position, as you said in the report, which is fantastic, and that's great to be leading on that side. I guess my question was really about the 78-week reduction and your confidence in terms of the trajectory, because part of waiting list management is that validation of the waiting list, and about your assurance that you can give the board in terms of the accuracy of the figures that we've got in order to achieve that trajectory.
Thank you, Vicky, and just taking the opportunity to add in a little additional element, Jade, around the assurance. Obviously, we've got ongoing industrial action as well. So in addition to the point about validation, which Vicky's made, I just wonder if you can comment about the risks of industrial action to the trajectory, which would be helpful. Thank you.
Thank you. So with regard to 78-week or waiting in excess of 78-week, it's now a couple of specialties that have very complex procedures, or indeed one of our vulnerable services, so the orthognathic pathway. For that area, the validation is conducted weekly across the ICB and with our trusts. And indeed, there's an NHS reporting requirement, which is bi-weekly. So we track those patients and the validation is conducted both clinically and from an administrative perspective. For the broader group of patients that could be at risk of breaching 78 weeks, and it's the same process for the 65 weeks. So we're starting to move down our time bands, which is pleasing to see. The validation is underway by both acute trusts, and they are working towards the validation of being at 12 weeks. So all patients above 12 weeks are receiving regular calls, both in terms of it serves as a touch point, as we heard in the patient's story, in terms of you're still on this waiting list, are you okay to wait? Has there been a deterioration in your condition? So all of that information is collected, but also it gives an opportunity for the patient to hear that they're not forgotten about, they are on a waiting list and will be seen. Information at that point is also shared about the length of wait that they're still waiting for. So what's the likelihood of your appointment? So that information is passed on to the patient. The validation, there's a national requirement around that, and both trusts are adhering to that. That's helping make sure that the waiting list is as accurate as possible. But on top of that, some of the specialties are conducting clinical validation in order to support the clinical prioritisation of patients. So what I mean by that, as well as the national requirement, our trusts are going above that in some of the specialties. So particularly areas whereby they feel there is more risk of that waiting list expanding. So then that's really great to see as well. In terms of assurance, the ICB can see this on a weekly basis, and we have an operational meeting on a Monday involving both our chief operating officers and our chief medical directors. So it is a great opportunity at that point to identify further areas of mutual aid. So that's how we're bringing that waiting list down, and an act on the validation results that we're receiving.
Thank you, Jade.
Thank you very much, Jade. Mark?
Thank you, Christian. Just a couple of comments. The work that goes into this, I know, is extensive, and the trajectory is good. and if you can feel a but coming, then you'll be right. But the targets that are set nationally, centrally, are nothing like what a patient would really have a target set. So I just want that little reality check. Even when we hit 52 weeks in whatever trajectory it is, there's not a patient around that would want to wait up to 12 months for their procedure or operation when they're in potential pain. So I just want that reality check of even these centralised targets, which I assume at some stage were based upon capacity, potential efficiency, and all the things. And I know they're centrally set, but it's still an awful long time, even when we hit our targets. And I just wanted to inject that patient perspective into the thinking and discussion. Thank you.
Mark, thank you. Very welcome reminder. I think if we need it to, just think about this from a patient perspective, and particularly linked to the patient story that, in fact, Kath also shared earlier, which is also a really good opportunity to reflect. So, yeah, so the focus on, getting beyond the target, I guess, and to delivering the kind of care that we would want to. I think Mary referenced sort of more traditional referral to treatment times that we might want to, which is where we'd really want to get to beyond this particular point that we're at. But Jade, anything you want to add in relation to that?
Yes, in response, Mark, I think that's why the summary of the risks is as it is recorded on page 10 and 11 of the report. We are not content with achieving the national targets around these areas. It is not acceptable, and we apologise for the length of time this recovery is taking, and therefore the risk is significant for our system. Each of the specialties that I've spoken to, the clinicians and the operational staff, are all share that view. If they can reduce the waiting times, they are endeavouring to do so. And indeed, we've heard a bit about the industrial action, but also I think it's worth noting that our staff are engaging in waiting list initiatives to bring the waiting list down also. The diagnostics is quite key in all of this. If we can bring the waiting times down for that, and therefore for those patients that are referred into a secondary care system, then the secondary care system can engage in the outpatient appointment and the diagnostic, and therefore with confidence we would know what patients are waiting for. Then that helps manage the presentation for the patient and clinically have a really good picture and understanding of what that patient needs. That gives us confidence then around the prioritisation, the urgency versus the routine. Give you assurance that the urgent treatments are being conducted. It's the routine ones that we're endeavouring to bring down the waiting list as quick as possible. However, the workforce challenges, the sustainability of some of the specialties is making this a really difficult area. But I accept Mark's view, and it is an issue, a subject matter that's always debated at the Elective Cancer and Diagnostic Board.
Thank you very much, Jade. So I think we've had a number of comments and questions raised about this deep dive. I don't see any more coming, but notwithstanding Mark's point, which is really important to think about this from a patient perspective, there are some significant steps forward in reducing the waiting times from, I think, a previous report that was brought to the board. So I just want to acknowledge the amount of work and effort that must have gone into everybody working together to try and improve that situation, because I think it's really important to recognise the progress that has been made. There was a point at which we were looking at much worse, I think, in terms of achieving the 78-week position, and we've done well, and I thank Jade and colleagues around the system for all the efforts to improve this, and know it will continue to be a significant focus going forward. So thank you very much. And I think at this stage we're really just asked to note the progress, and obviously we'll hear more about this in future reports. So thank you very much, Jade. Really comprehensive. So we move on now to the System Quality and Delivery Report, which is our more general performance update. Mary, are you okay to present this, or did you want to hand over this to Jade too?
I think I should be okay to do this one. It should be quite short, if that's okay, colleagues. So, this is the risk-based report from the QRD, where we do the detail of all our quality and delivery risks. I'd just like to pull out 3 aspects from the report, if that's okay. So, urgent and emergency care remains one of our most significant challenges. We provided you with some benchmarking to show the position across the region is equally as challenged from a 4-hour standard point of view. Our particular issue of over-hour ambulance delays at Worcester Acute. Have to say, in the last few weeks, we have seen some periods where there's been much improvement, which is really welcome to see. And we were working with the trust to continue to embed some of the changes that have been made in the last few weeks. That's helpful. Both place-based systems have now got an urgent care recovery plan to achieve the targets outlined in the report. The Worcestershire one, it fully includes the Dr. Ian Sturgis recommendations. And we've put in a strong governance around this to make sure delivery at pace happens. In Worcestershire, we've got a window of opportunity before the new ED opens in October and before winter is inevitably upon us again. That is challenging because of the industrial action and the focus there is on that. But the system is working better together, I think, to try and deliver some of those recommendations. So we will watch with interest over the summer how the impact of those actions are seen. Moving, I won't go into elective care and diagnostics for obvious reasons, but cancer services. Just want to say, pleasingly, we are on trajectory to deliver our faster diagnosis standard. That's the standard for patients to be seen and diagnosed with cancer. Both place-based systems are doing really well, and this is a direct result of our system going through pathway by pathway, cancer best practice pathway by pathway. It's been a very long and a challenging process, but it showed us where we needed to make the changes and put capacity in, particularly around diagnostics, to help us to get to that standard. So we're working hard to make sure that we deliver that trajectory at the end of the financial year. For our patients waiting treatment, there is one specialty that if we can resolve the issues, we would be able to resolve our 62-day position, and that's urology. There is multiple issues that I won't go into here, but as a result of that, we are calling a system-wide meeting, again with partners from region, etc., to resolve some of these urology challenges. Pleasing to say, Wye Valley Trust are helping Worcester Acute in quite large amounts at the moment, which is really pleasing to see. We have got 2 robotic operating theatres now, unable to use one because we haven't got the governance in place yet, and we're working hard to get that in place. But if we can resolve urology, we will solve our long-term cancer wait, which would be a significant benefit to our patients and to our system as well. So that's our focus. And then the one last thing I'd like to raise in the vulnerable services, I think it's an example of where our vulnerable services framework, designed by Jade, I have to say, which is a really positive framework, is on haematology. We had a very difficult position in haematology probably 6-8 months ago, where we were concerned we were going to have to take services out of our counties. And with the work that we've done, we've now got a much more stabilised service, and it shows the approach and the delivery of the framework has really helped us. I'm not saying it won't be vulnerable again at some point, but it really has helped us to be put in that position. So that's what we're continuing to do with all these vulnerable services. So happy to take any questions on the rest of it. Okay.
Thank you, Mary. David.
Thank you, Christian. Thank you, Mary. Just 2 points, really. One was to really welcome the improvement in cancer, Mary, and especially the way you describe that systematic approach of going through, service by service to address the issues. I think that's a really great approach. The other was I wanted to ask for assurance that you said all, and then I think you said some of the Sturgis recommendations would be implemented before the new ED opens in Worcester Acute in October. So my question was, are you assuring the board that all the Sturgis recommendations will be implemented by the time the new ED opens?
if you look at the plan that I think I'm sure I've circulated around to you all, some of the timescales of some of the Ian Sturgis recommendations, the actions will be after October. That's because some of them are longer term culture issues, changing practice in a large amount of practitioners, and that is going to take some time. What I think the priority is between now and the 1st of October is getting in place the pathways that mean patients don't go to the ED when they don't need to, and this is a regular discussion with the trust. So the same day emergency care, the hot clinics, all the things that the GPs on the gallery want to access instead of sending a patient to the ED unnecessarily. If we can do that, we can reduce the amount of patients outside in ambulances. If we can get at least that done in the next few weeks, that will really help us. So we are, one of the focuses with the single point of access for GPs. We want to deliver at pace, and we're encouraging the trust to deliver that at pace as we speak.
Okay, thank you.
Thank you, Vicky.
I think, Mary, just a follow-up question on the improvements that you've seen in June. And I guess it's the same question about Ian Sturgis' actions. So are you confident that it's as a result of the robust implementation of some of those actions, or could it be seasonal? How confident are you that that's going to continue, those improvements?
Thank you. Thanks, Vicky. I mean, we haven't really seen a seasonal change. In the last few years, we haven't really seen a seasonal change at all. In fact, June is often one of our worst months for some reason. I'm not sure any of us know why. I think it's a combination of some of the implementation of some of the small actions, but also the new Director of Capacity and Flow is really embedding her programme of work and day-to-day management of flow. And we can see some improvements definitely on that at certain times. We still have a weekend problem. We still have a recovery from the weekend problem. And the 7-day services that we need in place that aren't in place are an issue for us. So, you know, there's still much more to do, but we can definitely see periods of improvement in the last few weeks.
That's great. Thank you, Mary.
Thank you, Mary. Simon?
Yeah, thanks. I was just going to come in to offer some reflections, really, which hopefully might provide some assurance. I'm seeing more ownership from the trust of the internal actions they need to take to make improvements, more ownership than I've seen for quite a while, if I'm totally honest. And that's a bit to do with Ian Sturgis's work, which I think is bringing into sharp focus. And let's be honest, the vast majority, and 80–90% of those recommendations in that report are things the trust are going to have to do internally. They're about internal processes, internal behaviours and culture, how the bits of the hospital work together. That's where the focus is, and I'm seeing much better ownership of that. I also were in regular contact, obviously, with Glenn Burley prior to him formally taking up his role. Glenn knows this is #1 priority. He's talking about asking Ian Sturgis to come in actually and help him implement some of the behaviour and cultural change issues, which I'm really encouraged by, because it just tells me the trust are embracing and owning the challenge in a way we probably haven't for the last couple of years. So, it isn't going to be overnight, but we're definitely making some really positive steps in the right direction.
Thank you, Simon, and thank you, Mary. Just wondered if you could comment further on what we're doing around the sort of vulnerability identified around dermatology.
Yes, we have quite an emerging issue at the moment around dermatology in Worcestershire, largely, which means that we by August we could be in a very difficult position to provide acute dermatology services. So I think, as Jane said, on Tuesday next week, we'll be chairing a system-wide meeting with our partners around us, other hospitals around us, exactly the same approach we took with haematology, to resolve the here and now issues. How are we going to maintain the services? How are we going to maintain the clinical pathways? Then what do we need to do in the medium term to sustain our service across our ICS? Dermatology is a complex service, a very complex service with community-based dermatology and acute dermatology. We're going to talk to our GPs again about specialist interests and what we could do in the community to keep more patients out of the acute. We've got teledermatology in place, and we're just doing the artificial intelligence work on dermatology as well. So we're doing all the best practice we're told nationally, but we've got to find a solution in the next few weeks to to resolving the here and now issues at Worcester Acute, which we can feed. I'm happily send round a brief to people after that meeting next week to give them the actions that we're taking, a bit like we did with hematology.
Yeah, thank you, Mary. So the lessons we've learned clearly from the work, the excellent work that was done on haematology, we can implement here, and really good to hear the immediate actions being taken to address that and grip the issue. So thank you for the update. We note all the points that have been raised in relation to current risks and mitigations, and thank colleagues for all the work that I know is going on to manage these things. Okay, we move on then to item number 13 on our agenda, which is the financial plan and delivery relating to 23-24. Over to you, Mark.
Thank you very much, Chair, and good morning, everybody. So the paper today updates then on the month 2 financial positions. That takes us up to May in the financial year of the plan for 23-24. So just to remind the board, as we previously discussed, we've got a plan for 23-24, which is a £19.2 million deficit plan. That was the collective plan submitted by all partners across the system. So at month 2 then, the collective ICS position is a £13 million year-to-date deficit, which currently we are £3.7 million behind the phased plan. So the phased plan for 23-24 had the system having deficits for H1, so that's the first 6 months of the year, moving then into a surplus position in the second half of the year, ultimately then finishing the year in that collective 19.2 million deficit position. You'll see within the report then that Worcestershire Acute Hospitals accounts for £3.2 million of that variance. And you'll see on page 3 of the report that there's a number of drivers linked to that. So elective recovery fund, predominantly linked to the additional work that's happening in the hospitals. There's an assumption in there at the moment that for April, because it's only based on April data, that we're behind where we need to be. There was a plan phasing issue with Worcestershire Acute, so their internal trust plan is slightly different to the plan that's been submitted to NHS England. It's only a phasing issue, but that is accounting for part of the variance. And as we've already heard, the additional work that we're seeing around trying to bring that backlog down in elective activity, we are seeing more insourcing costs, so that's organisations coming in and using the Worcestershire Acute facilities to help clear some of that activity that's generating an additional cost. Now, when we do what we call a cashing up exercise, and we look at how much actual activity has been delivered at tariff linked to the elective recovery fund, I'd like to be able to sit here and say we've gone above our elective recovery fund target, and therefore we're going to bring in some more income from the nationally held pot for activity. The challenge as I sit here today, though, is we haven't seen the month 1 actual weighted activity yet from NHS England, and we know, because some of the challenges linked to industrial action, there are ongoing conversations with government about what the right elective target should be for this year, because we've seen industrial action in April, May, June and in July. And as Simon's already mentioned, that he's having an impact on the work that we're able to go through at the moment. So part of what's driving the plan position as well at this point is we are incurring additional costs linked to industrial activity. And at the moment, we're in the process of collating that to report back to NHS England. I don't believe that will unlock any more additional income, but it's a legitimate reason as to why we are off plan and seeing costs that weren't in our original plan, because we didn't plan for industrial action to be carrying on as long as we're currently seeing. So that is a driver of what's in that position. You'll also see within the report then that efficiency across each of the partners continues to remain a risk. It's also a big focus across the system at this point. So collectively, we are £1.7 million behind plan. at this stage of the year, and more work is underway looking at A, how do we get more recurrent delivery? B, how do we ensure that where we've got areas that are still slightly unidentified, we get that built in and we get those plans identified and starting to deliver, and B and C, look at what the opportunities are then to claw back where we're under delivering. We need to get back to plan because the delivery of recurrent efficiency will certainly help our underlying financial position as we're going forward and developing that medium-term financial plan. Non-recurrent delivery, all that means is puts more pressure into the new financial year, and we're always playing catch up as opposed to really stepping down that underlying financial deficit. We've also touched on agency within the report. So month 2 agency broadly on plan, which is really good news, particularly given some of the challenges we've talked about, and we've had a lot of conversation, haven't we, about workforce pressures in various different meetings. Whilst our overall plan is slightly above the agency cap set by NHS England, it is a significant reduction on last year and looks to take out £23 million during 23-24. It still is early days, but the controls and the processes that are in place are really good. My only nervousness, though, is the ongoing industrial action and pressures in that area when we are having to keep services safe and put mitigations in might drive costs in some of these areas. I wanted to just specifically pull out something then in relation to the ICB financial plan, particularly on prescribing expenditure. So when we prepared the report, we hadn't seen any prescribing expenditure. We've now received month 1, month 2 is just out, but we haven't worked through that yet. But month 1 is 10% above what we spent in April 22, so a significant increase. It's worth saying that is all predominantly price. When we've looked at prescription volume, that is down, so it is price that is driving this. From a planning perspective, we only planned for a 2.9% uplift, which was in line with the NHSE planning recommendations. So whilst we're not off plan at the moment, if it continues at that same level, that will give us a significant financial pressure and something we are talking continually to NHS England about. We've also mentioned previously then about as a system in deficit, that would give us some implications. So we've now been advised that we're going to have some enhanced financial controls in our system. These controls will cover what we call non-clinical vacancies. So it's not touching clinical services, these are non-clinical vacancies, and around any new non-pay expenditure above £10,000. At the moment, we're working very closely with all the NHS partners around how they're implementing these controls within their organisation, and through a specific ICS investment and expenditure forum, we will oversee these controls and ensure they're being adhered to. But alongside that, challenging partners and colleagues around, could we do things differently? Could we look at mutual aid? Could we look at sharing posts? Really as part of this journey around transformation around back office, and can we do things differently as we go forward? So this will be overseen by initially the Finance Forum, but subject to a later paper on our agenda and a change we would like to make. If that's supported, then potentially by the ICS Finance Committee. So there is assurance to the board that these controls are being adhered to, and we can work with NHS England then to give them assurance we are implementing them as required. So I think it's very early in the year, we're only at month 2, we've got continued inflationary pressures, challenges around efficiency savings, agencies looking good, but it concerns me given the ongoing industrial action and prescribing, as I've talked about. So it's really, those are some of the key headline risks that we're seeing early on, Chair, but I'm happy to take any questions or comments on anything in the paper.
Thank you, Mark. That's very helpful and comprehensive. Any comments or questions? David first, please.
Thanks, Trishni. Mark, a couple of questions. Firstly, you've said on page 2, you say there's a clear message that we're expected by NHSE to improve our position by the close of 23-24. Is there any quantification of that? So do we know how much we'll be expected to improve it by? And I think it's too early to say whether that's possible yet or not, but do we yet know how much we'll need to improve it by? That's the first question. And the second question is, are we confident that our system partners will deliver the efficiency and productivity savings which they need to deliver, and that they can be delivered without compromising patient safety?
Thank you, David. Two very good questions there. So there's no specific target as set by NHS England around improving the position. The first challenge was always we've got to ensure we deliver our plan. So we were always very clear as a system that it was a stretch to get to that 19.2 million. There was a lot of risk in there. So whilst we would always like to go further than that, it's not been quantified as yet by NHS England. I think given where we're at month 2, a key for me would be to get back onto plan and make sure we deliver what we said we would deliver to NHS England. In terms of the second question then, each of the organisations are working thoroughly through their efficiency and productivity programmes, and we know their key strands in terms of improving quality. So if we can improve quality, we've already seen that there is an improvement in cost and what we spend in some of these areas. So all of the efficiency and productivity schemes are subject within the trust to QIAs, the quality assessments, before any schemes are put in place. So I'm confident they're doing that QIA process on all of those. As I say, they're off plan a little bit at month 2. There is some catch up. So we are going to do some work with them to look at, are there further opportunities? Are there things we can do collectively? But then also as a system, we're working across the region, looking at what all other areas are looking at around efficiency and savings opportunities. And are there things there that others are doing that we might not be doing that we could look at and implement at pace to potentially get back to where we need to be? So there's that sharing going on at the moment across the region. So hopefully that answers your questions, David.
It does. Thanks, Mark.
Thank you very much, David. Graham?
Yeah, thanks, Krishni, and thanks for the report, Mark. Mark, if you forgive me, as usual, I've got a multi-part question coming up. So the first part was, again, it's related to the elective care recovery funding. And I know we had some stretch targets for the income there, particularly from the independent sector. I didn't see reference to that in your report. Could you just give me some idea on, is there risk there? The second part was, it looked like to me, and it may not be, some inconsistency on the impact of strikes and the use of agency and how that's being put into forecasts by the different trusts. Do we have an overall picture of what the strike impact would be, and is that consistent, and how that's being recorded from the trusts? And I suppose the final point, and absolutely fully understanding, Mark, that this is period 2 we're looking at, but we are creeping towards the end of period 4 in real time. If the various phasings and the various programmes didn't come to fruition, have you as a system lead got a point where you would actually say we need additional schemes? And I understand that there is a medium-term plan that you're having to present to NHS England, but I think that's in October. Would that give enough time for any additional schemes to come into effect?
Thank you, Graham. A number of questions there, and I'll pick up on them as I go through. So in terms of elective recovery funding, I think the first thing I would say is it's complex. So there's £32.7 million attached to recovery of a system-wide target that is 108%. And that's 108% above the 1920 activity that was actually delivered. Part of that is going to be fixed, so I think it's 84% of that is now fixed. The other element of that 16% is variable. So what we're working through at the moment is where are each of the component parts against A, their individual target, and then B, where's that give the system overall? So from an independent sector perspective, we'd always assumed that because we knew from what they've been delivered in 22-23, and as Jay's already talked about as part of the ongoing need around the elective recovery, that we would be going further in our use of the independent sector. So we've got a plan that's currently around 120% of 19-20 activity delivery for the independent sector. And at the moment, the way that is funded, part of that is through the baseline that was set for the 23-24 plan. The other part of that then does require achievement of a stretched elective target that would give us some more elective funding at tariff. So until we get the month one data from NHS England, it's difficult to see what each of the component parts looks like. But from what I can see on the independent sector side, they are ahead of plan, which is good, which means they are doing the work and bringing the backlog down as we need them to. I now need to work through and ensure that that funding flows and we can cover that cost, but we've got that built in at this stage. In terms of inconsistency, that was one of the challenges I think Simon had put back to NHS England about we needed a consistent way across all partners to capture the costs associated with the ongoing industrial action. There's a template that we are just filling in by to close of play today, actually, Graham, across all partners to send to NHS England that is consistent, that we'll be able to submit to NHS England. So if you give me 24 hours, Graham, I'll be able to come back to you and tell you what that cost looks like at this stage. All we got at the moment was an initial assessment from Worcestershire Acute of what they'd seen in the first couple of months. And absolutely, we are, as we sit here today, heading towards the end of month 4. As I say, we're just working through month 3 at the moment, but the initial headlines show that there is still some more work to do. It's not, whilst things may have slowed, we're still not moving into the right direction yet. At the end of Q1 then, which is the month 3 position, we are now going to do a deep dive with each of the provider positions to understand risk, opportunity, mitigations, as I say, what additional efficiencies we might need to bring into play, where we think each of the organisations will be. That will give us a collective system position then, Graham, and we will then go back through the finance forum and through our QRD committee to say, this is what we think the forecast is looking like given what we can see. These are the actions we now need to put in place. So I would say, Graham, by at least September, at the latest, we need to be in a position, if we need to put additional schemes in order to bring back to plan, that's the point we'll need to put them in before we get into the winter season. However, there are some things that potentially we might not be able to do anything about it in terms of costs associated with industrial action. They were never in our plan. They're going to, is that something we can mitigate? I don't think we probably have that level of mitigation built in, if I'm honest, Graham. And also, if inflation carries on at the same level we are seeing, particularly what we're seeing on prescribing, we might not have anywhere to go in order to be able to deal with that. And that might mean we have to have a conversation about where that's leaving our financial position at the moment. But as we sit here today, we're committed to delivering that plan that we collectively submitted and signed up to as a system.
I think that's a very comprehensive response, Mark, to the questions that Graham raises. It does, I think the important point, just picking up on your last comment, I mean, clearly there are some risks that are, as you say, hard to mitigate. I think there's something there about the absolute granularity and confidence about our, you know, the data that we present to support and evidence those things that are harder for us to control, like the inflation issues, because I know that's something that Julian has always been really clear about, that we can, as long as we can evidence these things, it's really important that we're able to do that. And hence, I think Graham's point about consistency around the way in which we get the data or show the evidence around costs of industrial action, all of that is really important. So Mark, a final comment before we close?
Nothing really else from me to come back on, Chair, but thank you very much for all those questions, and we'll continue to advise where we are against each of those areas.
Great, thank you very much. So we note the position as it is, and clearly there are some risks that Mark has highlighted, that we should be updated about, no doubt, in future meetings. So thank you. Finally, in this section then, we have our Board Assurance Framework report. So it's to Hannah for this.
Okay, thank you, Krishni. So the Board Assurance Framework report provides a high-level summary of the Integrated Care Board strategic priorities and key areas of risk, a number of which we've already spoken about under various agenda items today. So a few things I'd like to pull out from this report. So first of all, we've had some positive moves since the last report with regards to a couple of areas. So firstly, it's priority 1, which is the development and implementation of sustainable system strategies. So clearly we've had the joint forward plan signed off and published that mitigates the risk in terms of buying into the strategic framework. So that's pleasing to report a positive move in that area. And the second area is around POD. So we have now taken formal responsibilities with regards to delegation of those services. So again, that area has moved in a positive direction in terms of level of assurance and level of risk. There have been a number of corporate risk register updates, so that's on page 4 onwards. I think it's a good thing to see lots of updates. It means the risk register is kept really live, and it is not just a report we kind of file away. We do actively monitor it, and committees are playing really key role in monitoring all of these risks. So some risks have been reframed and refreshed. Some have been reviewed in line with 23-24, particularly some of the risks relating to finance, and crucially some new risks have been opened. Particularly, I'd like to draw attention to risk 2.1023 related to ADHD assessment, prolonged waiting times. That risk is a high risk, has been scored at 20, so that's significant, and I know QRD will be doing a deep dive in this area in the coming months. We've also had some risk closures, which are detailed on page 5. So finally, in terms of next steps, you have received today the updated corporate objectives for 23-24. So we will, of course, refresh the BAF and the risk register in line of that and realign all our risks to those new objectives and priorities. And that will be included on the board report in September. So I'm happy to take any questions.
Simon, do you want to come in?
Yeah, thanks, Krishna. I just wanted to come in on that point that Hannah mentioned around the ADHD assessment waiting times. I mean, so that reflects a significant increase in referrals and a big backlog and waiting list building up. Clearly, if we did nothing, that would result in an extremely long waiting time. Obviously, we have no intention of doing nothing. There's a whole series of actions, which are twofold, really. One, working with the teams to increase capacity. And it's hard to increase capacity because there are workforce challenges, but there are a number of ways of increasing capacity, both within the current service and looking at the contribution partners, independent sector and other clinicians can make to those assessments. And secondly, obviously reviewing the referral pathway and the triage and just making sure, again, the assessments that take place are on those with the greatest degree of need. So there's a triage element. So clearly we are very well sighted on that change in demand, and there's a lot of action that needs to take place over is underway already, but that needs to take place over the next month or two to try and make those changes to capacity and to the pathway to that. Just it's a little bit more context than, you know, it's a little bit alarmist really, the fact that kind of waiting list, but just to give people reassurance there's a lot happening to make sure that doesn't turn out to be the case.
Thank you, Simon. Helpful context. Vicky?
Thank you, Hannah, for the report, and it obviously shows the positive management of the risk register, so that's fantastic to see. Just a couple of queries really on page 4, corporate risk 2.2, about the community paediatric services, because it's saying about the absence of an executive lead, but I know this came up in QRD in the main meeting because actually there is the director of nursing in Hereford is the exec lead, so that just seemed to be lagging behind a little bit. And then just a question about the one that's closed, which is 012, corporate risk 2.1, about dermatology. And it may be a different aspect of dermatology, but again, in other papers, we've talked about the frailty. This risk was around staffing and data reporting, but we've got a risk in the other area of fragility around dermatology. So it was just querying, was that appropriate to close at this stage?
I will bring Jade in on this, if that's okay, Jade.
Yes, certainly. So with regard to the risk around dermatology, that centres on the situation we were in earlier this year with a provider of community dermatology in Worcester giving their intentions to withdraw from our economy, and therefore that's what the risks is in relation to. It isn't associated with the vulnerable services of dermatology at Worcester Acute. Really pleasing to say that we have a new provider, Health Harmony, and therefore the risk can now be closed. They're now fully operational.
Yeah, that's really helpful clarity. Thank you.
Then in terms of that point you've made around risk 2.2 and the lead from Vi Valley Trust, you're right, Vicky, I think it's a bit of a lag there. So I believe the lead is Lucy Flanagan, am I right, Kath? Yeah, that is correct, yes.
That's correct, yeah.
Okay, that I think answers your questions, doesn't it, Vicky? So I'll bring David in.
Thank you, Krishni. It's a two-part question again, Hannah, I'm afraid. It's about page 3. So we look at the strategic risk scores over time, and it looks like the priority 1 high risk, as in the red rated ones, are actually increasing. So we're now up to 3 red rated in priority 1. My first question is, which is that third one that's now become red rated that wasn't before? And the second half of the question is that lower down the page we see that our assurance ratings are improving. So actually we have greater and greater assurance, but is there some dichotomy there that it appears that our risks are getting more severe, but actually our assurance of those risks is improving? Somehow that balance doesn't feel quite right there.
Yes, thank you, David. I think some of it is what we have done following the board development session on risk appetite. We have moderated some of our risk scores for the strategic risks. The nature of the strategic risks, they are kind of the coming together of the corporate risks and sort of a bit of a weighted average. And we have previously had some, it's more of an art rather than science at the moment. So we've had some kind of discrepancies, I guess, between having several high rated corporate risks, but then it didn't really correspond to the level of the strategic risk. So some of this is purely just rephrasing and revising and bringing in line with risk appetite. I think in terms of the detail, if that's okay, I'm going to just take this away, David, and do a little bit more work on this. I wouldn't be able to give you a really detailed answer right here, but happy to take that as an action to make sure we've not missed anything and to make sure there are no alarming trends as you suggest. I do think it's more of an issue of process and the way we kind of illustrate the risks on the report, given that we have recently established our risk appetite.
Okay, thank you. And also the point about the priority assurance ratings, that seems like our assurance is getting greater whilst our risks are not improving.
Yes. I mean, and that shouldn't be happening. So let me look into that and I will provide an answer on that.
Thank you very much.
Yeah.
Great, Hannah. So you'll take an action away on that, and,
yes.
and just to clarify how that's reflected. And I think also that the report observed that we will actually be just reviewing this in any case, won't we, because of the new corporate objectives. So or the refreshed, we shouldn't say they're new, but they're refreshed, aren't they, to reflect the joint forward plan and other things that have happened in the intervening period, as we heard earlier. So this will need to be looked at in any case, but helpful perhaps just to make sure we've got the mechanics of some of that working effectively. But really helpful, as others have commented, to see that there is movement in the risk, because I think it's really important that our risk management processes are dynamic and are not seen as things that are just settled and stuck and we don't do anything to change them. So actively managing them is an important part of our role as a board. So thank you very much. Okay, we move on then finally to some governance matters that we do need to conclude as part of our business today. Hannah, it's back to you on both of these items. So first of all, we have some just some amendments to terms of reference that I think you want to bring our attention to, followed by an amendment to our constitution. So over to you on both of those.
Thank you, Krishni. So yeah, so the first paper is for approval of our new sets of terms of reference. When I say new, I do mean they have been newly written. There are some small amendments following a comprehensive committee effectiveness review and process which we've conducted over the last few months. That review took place in two parts. We did a desktop review and benchmarked the operation of our committee against some sort of best practice models, and we have also conducted a survey of committee members just to ensure that they are satisfied with the way the committee is operating and that all the business of the committee is being covered. That resulted then in some, in most cases, minor amendments to the committee's terms of reference, and that's detailed on page 2 of this report. In particular, probably the most significant change is our operational executive committee, where we have significantly reviewed and streamlined the membership of that committee. And there have been some further smaller changes made to other committees' terms of reference. So today, really, I'm asking you to formally approve those terms of reference, which have already been endorsed by the individual committees and their members.
Everyone happy to just provide their approval, as these have obviously been through a process already, but we do need to formally approve them. So thank you, Hannah. I think we have received approval for those. So the next item is the change to the constitution.
Thank you, Krishni. So this paper really outlines some of the rationale in relation to changing the ICB constitution by appointing an additional non-executive member with a focus on finance. So we have heard through Mark's report the financial challenges we are facing. We have previously also discussed the establishment of a system finance committee. This is something that other systems in the region and nationally are looking to do as well. I have also done some benchmarking with other systems in our region, and while we do have sort of about the average number of non-executive members, most systems have 4 and 5, so we are sort of slightly on the lower end. Most, in fact, I think all of the systems now in the region do have a non-executive member with a specific focus on finance. So I do think this is a bit of a gap that would be helpful to bridge, and it will obviously boost overall level of challenge and scrutiny on the board as well, and provide a balance to our board membership. So the process for this is that I'm seeking the endorsement of the board to make this change, but the change is formally approved by NHS England. So following your endorsement, I will then be submitting a formal request to NHS England to vary the constitution, and that approval should be granted within 4 weeks at the very latest. We'll obviously keep the board updated of the progress. So yeah, so that is it. I'm happy to take any questions. Otherwise, just asking for approval, please, today.
Thank you, Hannah. So I think there was a discussion about some of the rationale for this in one of our development sessions as well. And indeed, we talked to system NEDs, I think, about the suggested change as well. So again, obviously happy to take any questions, but if people are happy to approve that, then we will take that forward in terms of getting approval from NHS England, which, as Hannah said, we will need to do in any case. Everyone happy to support that? Okay, good, excellent. Thank you very much. So Hannah will take that forward to NHS England, and obviously subject to their approval, we will then start a recruitment process, a robust recruitment process for ensuring we have an additional resource. But it felt really important, I think, because obviously the challenges around finance are not going away, are going to be with us, I think, for some time, and reflecting also that we want to put the finance forum on that formal footing. This felt like an opportune moment to to change, to make that change. So thank you for your support for that. We have been remarkably efficient today, and have somewhat exceeded my expectations in terms of how long this meeting would take. So our next meeting is Wednesday, the 20th of September. But in the absence of any other items of business, I will bring this meeting to a close. I am conscious that we are due to meet in private for a matter of business that we need to deal with confidentially due to the commercial nature of that item. And I just wanted the board's permission to bring that forward to 12 o'clock, if that's okay, so that we can conclude that item of business rather than the current time. So if colleagues are okay, there's a separate link for that meeting. If we could join that at 12 o'clock, we can hopefully conclude that item a little bit earlier as well. But thank you everybody for contributions today, and also Jade for coming in and supporting the item. Paul.
Thank you. Just under any other business, people will probably be aware, but I just wanted to inform the board that Worcestershire Children's First and the County Council have received a good rating from Ofsted for their children's services. I'm just wanting to thank all of the partners and everybody who has been involved across the system. It is very much a system assessment, and it is another one of those things that shows our improvement in terms of the system. I just wanted to bring that to people's attention. I think it's a really big achievement, taking 5 years of lots of work with all people across the partnership to get to where we are. But again, it shows that the system is working and we are getting the improvements we need. So just wanted to bring that to people's attention.
Well, thank you very much for sharing that. I think that's really important recognition of our work together, and really helpful for us to note and yeah, celebrate the improvement really, which is what we're all here to do. So thank you very much for bringing that to our attention. Okay, so let's close the meeting, and we'll see you as I say, in the separate link at 12 o'clock. Thank you.